So an interesting area is, am I ovulating? Am I releasing an egg? And so if you have regular cycles, let's say a 28-day cycle, day one is day one of flow, a 28-day cycle, you've got to assume over 95% of the time, let's say mid-cycle, day 14, you're releasing an egg. And then that egg can get picked up by the tube, brought in the tube to potentially get fertilized. If you're irregular, what does that mean? Well, if your cycles are 40 days, 50 days, 60 days, once every 3 months, it's really hard to know when to have relations and if you're even releasing an egg. And if people who are irregular, it's hard to time things, and you kind of feel like you're almost wasting your time. So if you're irregular, what you really want to do is you want to find out, is there any reasons why I'm irregular that I can fix? Like, some people who have some different weight issues, they're irregular, but if they get in better health with any of the doctors on the panel, we know they will start cycling regularly. Completely valid. A lot of people don't want to take a medicine like Clomid to make them cycle regularly. What you can do before that is to say, you know what, I want to detox, I want to get better shape, I want to use my elliptical, get myself where I want to be, and then you'll start cycling on your own. We know that people who lose, let's say, 15% of their weight in some situations, they'll start cycling on their own. So, a very important area. So you need to ovulate, you need to mature an egg and release it in order to get pregnant. Ovulation kits and fertility monitors are out there. We'll talk about that. The ovulation kit is telling you that you're having an LH surge, which is a hormone that will tell the egg to get mature and to release out of it. And an LH kit, these fertility monitors can help you take control and help you time relations. And again, we kind of talked about this, irregular cycles, PCO, an area that's very, very interesting, very much helped with nutrition, an area that we see a lot of patients in our center. And Carolyn, our nutritionist, sees a lot of patients with PCO because we know if we can get them on to better health, they'll start cycling now during their pregnancy, they're going to be healthy, and we'll give them goals for the rest of their lives. So, and a thyroid and prolactin, thyroid disease can make cycles irregular. So these are some basic things we look at when people are irregular. So I threw in this slide of the menstrual cycle. We know that the menstrual cycle starts on day one. Day one is real flow. So you start it to day one. You will have a bleed. You will thin out the uterine lining. On your ovaries, you have hundreds of thousands of follicles. And every month, via the dominant follicle theory, you're going to bring up one follicle. And that follicle is going to grow to about 2 centimeters at mid-cycle. At 2 centimeters at mid-cycle, estrogen levels go up, which thickens up the lining. And estrogen will be the signal to give you an LH surge, which is the hormone that's going to tell the egg to mature and will help the egg pop out. And that's what you're picking up on your ovulation kit or your fertility monitors, the LH surge. So when your LH surge is peaking, you assume the egg's going to pop out, within the next 36 hours. So when your kit is positive, we want you to have relations that day and the next 2 days because we assume the egg's going to be sitting on the outside of the ovary, ready to get picked up by the tube. And remember, after the egg pops out of the follicle, the corpus luteum makes progesterone to maintain your pregnancy and give you good implantation. So let me jump into quickly what we do a lot of, which is trying to get people pregnant with regard to a little bit of assistance. We do a lot of superovulation and also IVF, and I kind of wanted to run through that a little bit just to talk about it. So we've all heard of Clomid. Clomid's a hormone, and it's used sometimes as first basis to try to push people on to try to get them pregnant sooner. It's used really in 2 situations. The first situation is superovulation, and the second situation is induction of ovulation. I want to jump to this part right there. Again, if you're irregular, the ultimate is to do all the things we've all been talking about, because then you're doing it naturally and you can make your cycle regular and get pregnant. If you've exhausted everything and you're not regular, then Clomid is an agent that is taken by mouth. It's usually taken for 5 nights, and that will make you have a regular cycle, develop a follicle at a very known time so that you can either have relations at the right time or do an artificial insemination. So Clomid will help someone's cycles become really regular when they're irregular. So that's one indication of Clomid, which is I'm irregular, make me regular so I know when the egg's going to pop out and it will help me become pregnant. The other issue with Clomid is something called superovulation, and this is where someone may have regular cycles, remember on my diagram, they're pulling up one egg and releasing one egg, but they haven't gotten pregnant in, let's say, a year. So what superovulation is all about is to say, you know what, this is kind of a numbers game at some point. We're going to take Clomid to make not one egg, but we're going to make 2 or 3. If we have 2 or 3 eggs sitting on the outside of that ovary, then we have a higher chance of pulling an egg into the tube. So that's a modality to try to stack the deck and try to get you pregnant sooner and have more eggs around to get picked up. We like people when you're doing Clomid to be monitored because we want to know how you're doing. We want to know that your uterine lining looks good and that you're developing nice follicles and that the cycle is going correct. We like people to add in insemination where you're, especially if you have a male partner whose count is a little bit low. We know that when you have relations, less than 10% of the sperm gets in the uterine cavity because the most die in the vagina. So when we place your partner sample into the uterine cavity, we can get egg and sperm even that much closer together. And you know, a hot topic is when you come to the point and you're doing this, how much of it should you do? We know that you want to do 3 or 4 cycles because if you're going to get pregnant on this modality of Clomid, it's going to work usually within 3 to 4 cycles. And I think how I see it is we know the literature. If it's going to work, it's going to work within 3 to 4 months. It's interesting that we have the Connecticut Mandate. Now, the Connecticut Mandate was a bill that was signed by the governor in '04, and I think she did a great job. Because what she said was to a certain amount of people with different insurances is if you don't get pregnant on 3 to 4 cycles of Clomid, we really want you to move into IVF. That's not what this discussion is about, but it shows us that sometimes public policy is fair, and we don't want women who need to do this, and this is not everybody, but some people need to use Clomid. We want them to do it a certain amount of time, be efficient. If it doesn't work, we don't want them to be sitting out there doing Clomid for a year. We want you to do Clomid, pull it off. If you don't, then you can move into IVF and more aggressive modalities.